Hello, my name is Kyle Geiger. I am a fourth year medical student at the Elson S. Floyd College of Medicine at Washington State University in Spokane. I am submitting this abstract for the clinical vignette category. Its title is Limited Treatment Options in Primary Hyperoxaluria with Renal Failure. Primary hyperoxaluria, or PH, types 1, 2, and 3 are autosomal recessive disorders with errors in the metabolism of glycoxylate and oxalate. In these disorders, serum oxalate levels rise due to overproduction. The kidney tubule is a main target for oxalate deposition, resulting in damage to the organ. The incidence of PH is estimated to be 1 in 58,000. Type 1 is the most common form, accounting for approximately 80% of cases. Types 2 and 3 account for about 10% of cases. Kidney failure is rare in these patients. By comparison, there's an increased incidence in secondary hyperoxaluria, resulting in advanced chronic kidney disease, injury in the setting of gastric bypass surgery, and enteric disorders such as inflammatory bowel disease and short bowel syndrome. Other reports of non-enteric secondary hyperoxaluria are seen in instances of excessive vitamin C ingestion. We present a 67-year-old female with end-stage renal disease, likely due to PH type 2 or 3. The patient was a 67-year-old female with end-stage renal disease, and the etiology of her renal failure was unclear with no obvious risk factors. She initially presented with a 1-month history of nausea, vomiting, and a 20-pound weight loss. There was no past history of enteric disorders, malabsorption, or the use of vitamin supplements. Her serum creatinine was 4.91 with a BUN of 81. A kidney biopsy showed oxalate nephropathy, figure 1, with tubular atrophy and interstitial fibrosis, seen in figure 2. The patient underwent genetic testing for AGXT, the mutation seen in PH type 1, and was negative. She is currently on a low oxalate diet and taking vitamin B6. However, her plasma oxalate levels remain elevated at 60.4, with the normal range being 1.3 to 3.1. Despite excellent dialysis adequacy and treatment adherence, her interdisciplinary team concluded that her oxalate levels were so high that a kidney transplantation would not likely be successful. In PH, specific deficiencies of hepatic enzymes cause oxalate overproduction. Oxalate deposits in the kidney and can lead to nephropathy and possible kidney failure. Genetic studies aid in the diagnosis of PH, typically showing mutations in the target genes AGXT, GPHPR, and HOGA1 for types 1, 2, and 3, respectively. Negative testing for PH type 1 led us to believe that our patient has PH type 2 or 3. The diagnosis of PH type 1 would make the patient a potential candidate for combined liver and kidney transplantation. However, treatment for those with end-stage renal disease for PH type 2 and 3 is unclear. Renal transplantation was evaluated, although outcomes are poor. Because of this, further genetic testing for type 2 and 3 was deferred because it would not impact clinical decision making. Our care team is exploring the option of an expanded donor kidney transplantation, and this is currently under evaluation. There is a paucity of information in the literature to guide our clinical decision making in this context. The role of liver transplantation in addition to kidney transplantation remains ambiguous. However, it is thought that this may be curative because GRHPR enzymatic activity in the liver is high, and recent case reports are promising. This case presents a unique diagnostic challenge where kidney biopsy was instrumental. Thank you for listening to my talk.